Good morning and welcome to our wonderful presentation this morning. I'm Dr. Eric Voth, been a part of Isaac and was one of the founding members. And now we are all pulling our forces together to try to make a difference in this very difficult issue. Very briefly, my personal involvement goes back to the 1980s. And I recall very clearly listening to the proceedings of a normal conference. And at that point, there was a declaration that they said they hoped to get the camel's nose under the tent with medical marijuana to gain legalization of the drug. And that hit me very strikingly. And at that point, I became very committed to trying to do something about this and really deal with it as we would any other medication or any other drug of abuse for that matter. So today we have Dr. Madeline Meier. We've had a wonderful conversation getting ready this morning. Dr. Meier is an associate professor in the Department of Psychology at Arizona State University. By the way, I know many people there, and I suspect that the use of marijuana is something you can really get into there. Anyway, she is the area head and co-director of the clinical training division for the clinical psychology doctoral program. She earned her PhD in clinical psychology at the University of Missouri, completed her clinical clerkship at Durham Veterans, which is a wonderful place, and boy, a large place. Her research focuses on the causes, force, and consequences of problematic substance use, particularly cannabis use. She's done prospective and longitudinal work and has co-authored over 60 peer-reviewed publications in this, funded by Arizona Biomedical Research Commission, and it examines trends in cannabis-related emergency department visits in Arizona. Dr. Meier serves on the editorial board of Psychology of Addictive Behaviors. She has provided invited testimony to the U.S. Senate on the cognitive effects of cannabis and has served on a National Academies of Science, Engineering, and Medicine committee focused on substance use treatment programs within the Department of Transportation. With no further ado, I hand off to Dr. Madeline Meier. Thanks.
Thank you for that introduction. It's wonderful to be here this morning. Okay. So today I'm going to talk to you about cannabis and health, molecular and population level insights from DNA to hospitalization trends. As you know, cannabis legalization is sweeping across the United States. There are now 40 states that have legalized medical cannabis use and 24 states that have legalized adult or recreational cannabis use. And Arizona, where I'm located, is one of them that has legalized both adult use and medical use. And we're seeing increases across the United States in cannabis use. These are data from NSDA, the National Survey of Drug Use and Health, going back all the way to 1975 through 2020. And what these data show is a large increase, particularly over the past 20 years, in the prevalence of daily or near daily cannabis use, past month cannabis use, and past year cannabis use. So we're seeing these large increases. And this is a concern in part because some evidence suggests that long-term cannabis use is linked to health problems, including respiratory problems, cardiovascular diseases, cognitive decline, and mental illness. Now, some of the research is more or less consistent, right? So the evidence for an association between cannabis and mental illness and cognitive decline is a little bit stronger than the evidence for cardiovascular disease. But on average, there is some evidence across all of these domains that cannabis has adverse effects on health. What I'm going to do today is talk about population level trends in cannabis related hospital visits and links with mental health related hospital visits, And then I'm going to shift into talking about differential DNA methylation as one possible mechanism that might explain how cannabis could have causal effects on adverse health outcomes. I'm going to present the results of 3 different papers published in the past year or so. First, start with trends in cannabis-related hospital visits in Arizona. I received funding for this research from the Arizona Biomedical Research Commission and from the ASU Substance Use and Addiction Translational Research Network. Okay, many states are using emergency department data to monitor the effects of legalization, and these states are showing a clear signal. The rate of emergency department visits related to cannabis, including cannabis use, abuse, dependence, and poisoning, has increased over time. These are data, for example, from Colorado, which showed that at the time that Colorado commercialized medical cannabis use, there was a large increase in cannabis-related emergency department visits and hospitalizations. This is important because ED visits represent an early warning for emerging trends and cannabis-related harms. They're among the costliest visits in the United States, and they are themselves considered a severe outcome. In most cases, cannabis is part of a broader set of health concerns when a person goes to the emergency department. It's not usually the sole reason. And what I'm finding in my research is that many of the people who visit the emergency department for cannabis also have co-occurring mental health disorders. It's somewhat unsurprising, right? Because we know there's an association between cannabis and mental health disorders. Explanations of that association include cannabis use may cause mental health concerns, and this evidence probably is strongest for psychotic disorders. Alternatively, mental health problems may lead to cannabis use. So many people have reported across the United States that they're using cannabis to manage symptoms like depression and anxiety. And finally, cannabis and mental health disorders could be related because they share third variables, right? They share these common background factors. And so there's all these reasons why cannabis and mental health might be related. And what I want to do is look in our Arizona data and determine if people who are coming in to the hospital in Arizona for cannabis also show co-occurring mental health disorders. Cannabis legalization in Arizona, here's the timeline. We saw that medical cannabis use was legalized in 2010 with commercial medical sales starting in 2012. And adult use or recreational cannabis was legalized in 2020 with adult use sales beginning shortly after in 2021. And the focus of the emergency department visits I'm going to present today is primarily before adult use legalization. So it's during a time when medical cannabis use was legal, but adult use was largely not legal. And I have 4 questions I'm going to answer. First, did cannabis-related visits increase over time in Arizona from before, so after medical legalization in 2016, but really almost before adult use in 2020? Were there particular population subgroups that are showing large increases in cannabis-related hospital visits? And are cannabis-related hospital visits disproportionately characterized by mental health disorder diagnoses? The data come from the Arizona Department of Health Services. So every state-regulated hospital in Arizona from 2016 to 2021 and 2022, that represents between 18 and 22 million emergency department and inpatient hospital visits in our state. And when a person goes to the emergency room or hospital in Arizona, just like most other states in the United States, physicians can list up to 25 diagnoses related to why the patient has come in. And they use a particular classification system called the International Classification of Diseases, or the ICD. And so what I did is I took all of these 18 to 22 million records of visits, and I searched them for the ICD diagnoses of cannabis-related disorders, mental health-related disorders, and other substance use disorders. When I say cannabis disorder, I'm looking for any diagnosis in a person's record that suggests cannabis use, abuse, dependence, poisoning, or an adverse effect of cannabis. I then looked for any evidence of a mental health disorder, and I looked across 14 different categories of mental health disorders, which I'm going to combine into a single kind of any mental health disorder for today's talk. But examples of these mental health disorders include depression, anxiety, post-traumatic stress disorder, schizophrenia and other psychotic disorders, and bipolar disorder. But I used an array of 14 different categories and said, in this record, is there any evidence for a diagnosis of a mental health disorder? And then I also looked for any evidence of a diagnosis of other substance use disorders, including alcohol, opioids, and so forth. So the first question I'm going to answer, have cannabis-related hospital visits increased over time? And I'm going to present to you the data in terms of rate of visits per 100,000 visits. And these are data from 2016 to 2022, showing that there were large increases in the rate per 100,000 visits for cannabis, a 40% increase from 2016 to 2022. And you can see here, I've highlighted when adult use sales started. So this increase that we're seeing in cannabis-related hospital visits in Arizona happened during a time before adult use sales. Next, I want to compare against alcohol-related hospital visits. I think it provides kind of important context for interpreting the cannabis trend. So here I'm going to show you the rate of alcohol-related visits per 100,000 hospital visits. And what we see is there was not a similar increase in alcohol-related visits. Okay, so what we saw for cannabis was not replicated for alcohol. Next, which population subgroups are showing the largest increase in cannabis-related hospital visits? I'm going to show you sex differences in visits as well as age group differences. So here are the data on sex, and you can see here I'm presenting visits for males and visit for females. And what's very clear looking here is that males show a higher rate of cannabis-related hospital visits than females, and that's true over time. Yet, what we see for females is a large increase in cannabis-related visits from 2016 to 2022. So while the rate of cannabis-related hospital visits is higher for males than females, females are showing a larger increase over time. Next, age group differences. What I'm going to show you here is the rate of cannabis-related visits per 100,000 visits for each age group in 2016. And then most recently, the most recent data I have in 2022. And I'm going to show you that relative change from 2016 to 2022. So here are the data. What we see here are the age 18 to 20 and then age 21 to 24 age groups show the highest rate. This is relatively unsurprising, right? It's young adults who are coming into the hospital for the most part for cannabis-related disorders. And we see that same trend again in 2022. But when we look at the change in the rate of cannabis-related hospital visits from 2016 to 2022, what we see is the two age groups with the largest increase include older adults ages 65 plus and teens, ages 10 to 17. So these two age groups are showing the largest increase in cannabis-related emergency department and inpatient hospital visits from 2016 to 2022. Next, I asked, are cannabis-related visits disproportionately characterized by mental health disorder diagnoses? So the question is, did visits with cannabis-related diagnoses show a higher prevalence of mental health disorder diagnoses than visits without a cannabis-related diagnosis? Okay, what I'm going to show you here is the prevalence of a mental health disorder. And again, this is any mental health disorder across 14 different categories of mental health disorders among visits where there was no co-occurring cannabis diagnosis. And that was about 3.24% of people who came in without a cannabis diagnosis had a mental health disorder diagnosis. But next, when we look among the people who had a cannabis diagnosis, 25% of them had a mental health disorder diagnosis. And this means that the relative risk of having a mental health disorder diagnosis was 7.7 times as high for people with a cannabis diagnosis versus people without. Okay. And this is unadjusted, not taking into account covariates. When we take into account the fact that people who come into the emergency department or hospital for cannabis may differ in age and sex, like I just showed you, that risk reduces to 2.32, but it is still statistically significant. So what that means is the relative risk of being diagnosed with a mental health disorder in the hospital is 2.32 times as high for people with a cannabis diagnosis versus people without. So just summarizing here what these data mean, we saw that cannabis-related hospital visits increased by 40% from 2016 to 2022, and we did not see a similar increase for alcohol-related hospital visits. And this has implications for what might be driving that cannabis-related increase. We know it's not clearly an effect of just adult use or recreational legalization because the study took place primarily before adult use recreational laws were passed. Another explanation is that this could represent, increased patient reporting because there's less stigma. It's more socially acceptable to use cannabis, increased provider surveillance. I don't think those explanations can completely explain this trend, in part because when we monitor cannabis positive urine screens, right, which don't depend on patient reporting, we've seen an increase in the prevalence of cannabis positive urine screens in the emergency department. So it seems to be the case that, at least to some extent, this increase in hospital visits related to cannabis use disorders represents just more cannabis use and more frequent cannabis use, and possibly an effect of increased cannabis potency. So the THC content of cannabis has increased dramatically along with commercialization. In the 1990s, cannabis had on average in the United States about 4% THC. And these days we're seeing averages in smoked marijuana with 20 to 30% THC. And some products, including concentrates, have upwards of 80% THC. So it's possible that the increased potency might be driving emergency department visits. In this study, we saw that the rate of alcohol-related visits to the hospital was higher than the rate of cannabis-related visits, okay? But that may change. And these are data here from NSDA, again, that showed that in 1992, 10 times as many people used alcohol daily or near daily as used marijuana daily or near daily, okay? But when we move up to 2022, we see that huge gap between daily use of alcohol and marijuana has narrowed substantially. And in 2022, there were more daily or near daily marijuana users than alcohol users. And so when I'm looking at this emergency department data, I'm wondering if over the next few years, right, my data went to 2022, we're going to start to see cannabis catching up to alcohol in terms of emergency department visits. People who visited the hospital with cannabis-related disorders showed elevated prevalence of mental health disorders. In particular, the risk of any mental health disorder diagnosis was 2.3 times larger for people with cannabis-related disorders in the emergency department or inpatient hospital than people without. So we're seeing this connection here between cannabis and mental health disorders in the hospital. And what does this mean for our state and for states who are, similar to Arizona and considering, medical cannabis laws and adult regulation? Well, an ounce of prevention is worth a pound of cure, right? I think we need to prevent problematic cannabis use and cannabis overdoses, right? People taking too much and ending up in the emergency department. I think we need messaging to counter the trend that we see in terms of people kind of increasingly perceiving cannabis as harmful. And this is especially true for teens and older adults, the two age groups here in Arizona that showed the largest increase in the rate of cannabis-related hospital visits. teens get a lot of focus, especially, in our state, right? There are programs that try to counter teen use, try to coach parents about how to talk to their teen and how to prevent their teen from getting access to cannabis. But what's less recognized is this trend that we saw in older adult cannabis use. And we need to educate older adults about cannabis risks, right? We need to tell older adults that cannabis today contains much higher concentrations of THC than, 15, 20 years ago. And we need to tell older adults that cannabis can be risky even if they're using for therapeutic reasons, right? There's very limited evidence that cannabis has a benefit for treating mental health disorders. And in fact, there is evidence suggesting that quitting cannabis improves mental health. And so this is a message I think that we need to send to older adults because they're an under-recognized at-risk group. What are the next steps? I plan to look at the effects of adult use legalization in Arizona, but I do need more data to do that because of the time lag in getting the hospital data, right? Every single visit in the state of Arizona to our Arizona hospitals, I only had data to 2022, and I really need data to 2025 to really look at the effects of legalization, but early trends are showing continued increase after adult use legalization. Another step is to conduct follow back and follow forward analyses. What I presented you today is visit level data, right? When I'm talking about what's happening in particular visits, but I'm actually now working on patient level data where I can track a patient and all of their visits to the emergency department or inpatient hospital in Arizona and find out if they come in for cannabis today, what does the next year look like for them, taking into account what happened in the previous year. And this allows me to establish which came first, a cannabis disorder or a mental health disorder. I'm going to show you some data that are currently under review based on this kind of retrospective cohort design where I'm following people who came into the emergency department or inpatient hospitals in Arizona for cannabis. And what I did is I identified people with an index visit to any Arizona hospital in 2018, and I grouped them. I said, did they have a cannabis diagnosis? If yes, they're in the cannabis group. That was 16,699 people. And then I had a group who came into the hospital in 2018, but did not have a diagnosis, and that was over 1 million people. And I selected people who were just ages 13 and over for this, as well as in-state residents only. And what I found, again, this is preliminary data under review, was that the people who had a cannabis diagnosis in 2018, they were more likely to come into the hospital over the next year for any reason. And this risk ratio, 1.28, they were 1.28 times as likely to come into the hospital for any reason than people without a cannabis diagnosis. And this risk ratio represents adjustment for co-occurring disorders at the time of their index visit, as well as adjustment for all previous visits in the year before their index visit. So this is adjusted for pretty much everything we can think of. And still we see that people who came in to the hospital for cannabis were at much higher risk of a subsequent visit. And I just want to call your attention to a couple other risk ratios here. That estimate was 3.11 for bipolar related illness, meaning that if a person came into the hospital in 2018 for cannabis, right, there was a cannabis diagnosis in their record, they were 3 times as likely to come in the next year for a bipolar disorder related visits after adjusting for all their concurrent mental health and prior mental health disorders, other substances, and so on. We saw a similar association for self-harm. So even when we look at the data by following patients, we're seeing that people who are coming in for cannabis are coming in again and again. And I think that has implications for intervention. I'm interested in trying out interventions in the hospital, for example, addiction consult teams that have the potential to help hook people up to services, healthcare services, that can treat their co-occurring mental health and cannabis and probably other substance use disorders at the same time. I also want to look, a next step is not just focus on mental health disorders, but look at some of the physical health concerns that emergency department doctors in my state are telling me that they're interested in, and particularly this cannabis-induced vomiting syndrome. All right, now I'm going to shift gears and talk about DNA methylation in long-term cannabis users, which is one potential mechanism by which cannabis could cause adverse health concerns. And the funding for this study that I'm going to present comes from the National Institute on Aging. So as I mentioned, long-term cannabis use has been linked to health problems in a number of domains. And it's possible, at least some evidence suggests biological plausibility, that cannabis has a causal effect. So some of that evidence includes cannabis administration studies, so experimental studies where people are given cannabis. They've shown that cannabis has acute, or THC has acute effects on the vasculature and on mental health symptoms, which means, if we can induce vascular effects and mental health symptoms in the short term by dosing a person with THC, it's more plausible that THC could have long-term effects in these domains. We also know that tobacco smoking has negative effects on various aspects of health, and most people who use cannabis smoke it. And so again, this cannabis smoking could lead to biologically plausible effects on adverse health outcomes. Epigenetic responses to substance use may be one mechanism that links substance use to health problems. And epigenetic responses mean a change in gene activity or gene expression that occurs without altering a DNA sequence. These epigenetic changes are responsive to the environment. So for example, drug use. So DNA methylation is the addition of methyl groups to the fifth carbon of cytosine bases, typically in the context of cytosine guanine dinucleotides, or CPG sites. DNA methylation regulates gene expression, and it's important for normal development. Okay, we need methylation, but it also plays a role in disease. Both hypomethylation, meaning you're not getting as much methylation, and hypermethylation can be harmful, but it really depends on the gene. And these methylation changes can be enduring, or they can be transient. I just want to give you an example about tobacco, because of all the substances, tobacco smoking has most consistently been associated with differential DNA methylation. Particularly the most robust and replicable CPG site associated with tobacco is CG055-75921. Many studies have shown that hypomethylation of that particular methylation site in smokers predicts the development of lung cancer. And what's really interesting about that site is some studies have shown that hypomethylation of that CPG site is associated with smoked but not non-smoked tobacco, suggesting smoking is the mechanism of methylation. Excuse me. And this particular CPG site is located within a putative enhancer of the AHRR gene, which encodes a protein involved in pro-inflammatory response and drug metabolism. So the methylation profiles of long-term tobacco users are well characterized. In contrast, the methylation profiles of long-term cannabis users are generally not. At the time I did this study, which is about a year or two ago, there were only a handful of studies in the literature that had reported on the methylation profiles of long-term cannabis users, about 8 studies. Okay, and just giving you a sense of those studies here. I looked carefully at these 8 studies and determined, in general, they did report on cannabis-related hypomethylation, but the characterization of cannabis use in these studies was fairly crude. many of the studies reported on methylation profiles of people who had ever used cannabis. And many of those people who had ever used might have used in a very limited way. We know that most people who use cannabis don't use very regularly. And many of the studies were characterized by small samples, not all, but many, and were probably underpowered to detect cannabis-related methylation or altered methylation. So what I'm going to do in this study is test whether long-term cannabis users show differential DNA methylation in midlife. And to do this, I'm going to leverage a very well-characterized prospective cohort with repeated assessments of cannabis use over many, many years of a person's life, allowing me to get a very kind of in-depth and nuanced sense of a person's cannabis use. And I'm going to focus on long-term cannabis use, unlike some previous studies, which were only able to distinguish ever versus never use. I'm going to focus on long-term use because we think it's the long-term cannabis use that seems to be most associated with health problems. And I'm going to evaluate methylation in midlife in this cohort because midlife is the time when we start to see substance use-related health problems. First question I'm going to ask is, do previously reported cannabis methylation associations replicate in a group of middle-aged, long-term cannabis users from an independent cohort? So as you can see, I'm going to take a replication-based approach rather than do what's called an EWAS or an epigenome-wide association study, because EWAS studies require huge samples. And the cohort I'm going to use is about 1,000 people, but nowhere near the size that you need for an EWAS. And my goal is to search that literature, those 8 studies that I presented briefly, that reported on cannabis-related altered DNA methylation, and try to, extract out all the different methylation sites, and then see if I can replicate them in this cohort. Second question, how do long-term cannabis users compare with lifelong non-users and long-term tobacco users? So the study I'm going to present, compares people with long-term cannabis use to people who've never used cannabis. That's what most studies do. It's a fairly straightforward comparison. But I also wanted to do a comparison with long-term tobacco users for 2 main reasons. One, many people who use cannabis also smoke tobacco. And 2, like I mentioned previously, the DNA methylation profiles of tobacco users are fairly well characterized. And so by presenting those profiles here, I can provide some context for the cannabis-related methylation profiles. Third question I'm going to ask is differential DNA methylation among long-term cannabis users robust to control for confounders? So I want to include a plausible set of confounders as covariates in my model to make sure that if I'm detecting a cannabis-related altered DNA methylation site, it's not better explained by childhood socioeconomic deprivation, low childhood self-control, family history of substance dependence, and persistence of tobacco, alcohol, and illicit drug use. So I'm going to include all of these factors as covariates to test the robustness of any cannabis-related differential DNA methylation. Fourth question, do any of the cannabis-related methylation markers represent meaningful biological associations? So what I'm going to do is examine correlations between cannabis-related methylation markers and whole genome gene expression. Fifth, does cannabis cessation reverse differences in DNA methylation profiles? Like I mentioned, sometimes altered DNA methylation can be fairly transient. So a key question I'm going to ask is, if a long-term cannabis user quits, does their methylation profile look less altered than the people who've continued using? Okay, so here just outlining my replication approach. Again, I searched the literature for any study on cannabis-related DNA methylation, and I found 8 studies. And from those 8 studies, I identified 296 unique methylation sites, unique CPG sites. And then in my array that we used, I had 246 of those that were reported in the literature. So I was able to go in and test 246 cannabis-related methylation markers from previous studies. In terms of the approach for data analyses, I'm going to ask first, do long-term cannabis users show differential DNA methylation at age 45 in midlife? And I'm going to do that in two ways. First, through group comparisons, right? Comparing long-term cannabis users versus non-users, and then also comparing tobacco users and non-users for that context, and comparing cannabis and tobacco. Again, I'm taking that group comparison approach because it's relatively straightforward to understand. And it really represents what most of the literature has done. So it's quite comparable to previous studies. But I'm also going to take a second and more powerful, statistically more powerful approach, which is testing dose response associations between kind of regular cannabis use over time, over many, many years in this prospective cohort, and these CPG sites. And what I want to see is agreement between these two approaches. So when I do these group comparisons, do I get the same hits, the same CPG sites associated with long-term cannabis use as I do in tests of dose response? And those CPG sites that are consistent across these two approaches in the same cohort, I'm going to select out and follow up, with tests of correlations with whole genome gene expression and tests to see if cannabis quitting might reverse DNA methylation. So the data come from the Dunedin longitudinal study, which is a prospective study of a cohort of people born in 1972 and 73 in Dunedin, New Zealand. The cohort's been followed now from birth to age 45. And you see here at age 45, the 94% of study members were still participating. So very low attrition in this study. And the ages here in this table show you the ages at which study members were assessed. So following birth, they were assessed at age 3, age 5, age 7, age 9, and so forth. And so we have very rich data at each of these assessment phases about a person's substance use, at least from age 18 onward, and health. So these longitudinal assessments highlighting here that between ages 18 and 45, we got past year reports of cannabis use, as well as diagnostic interviews about cannabis use disorder. So at ages 18, 21, 26, and so forth. And then at age 45, the study members gave their blood, and we were able to use that blood to scan them for epigenetic or DNA methylation. And we used the EPIC 850,000 bead chip, which means this contains probes that interrogate over 850,000 CPG sites. So the first approach I used is I wanted to compare groups, long-term cannabis users versus non-users, and long-term tobacco users. And so if you think about the study in terms of everyone in the study, this population representative cohort, what I'm going to do is, of all the people in the study, identify those that are long-term cannabis users, long-term tobacco users, and non-users. And then anyone in the study who doesn't meet those criteria, they're not a long-term cannabis user or a long-term tobacco user, for example, I'm not going to include them in these group comparison analyses. Here are data showing these groups that we were able to cull from the population representative cohort. We had a group of people, 86 people, who were long-term cannabis users. They were using cannabis regularly, at least 4 days a week, at age 45 at the time of the DNA methylation. And they had used regularly or were dependent on cannabis at least one previous wave. Okay, and what you see here is their mean days of use in the past year at age 45. So the long-term cannabis users in this study were using, on average, 257 days in the past year in midlife. The next group is the long-term tobacco users. Okay, this was a group that we selected out from the cohort that had used tobacco long-term. And what I want to point out here is the long-term tobacco users were selected specifically to not use cannabis. So This mean of 0.11 cannabis days reflects that the long-term tobacco group really did not use cannabis at age 45. So they were using tobacco, but not cannabis. And then we had this group of lifelong cannabis and tobacco non-users. They weren't using cannabis at all, obviously at age 45. And I want to point out about daily tobacco use because there's an important caveat here. The long-term cannabis users, about 63% of them were using tobacco at age 45. Okay. And then, of course, the long-term tobacco group, 100% of them were using, and then the lifelong cannabis tobacco non-user group, none of them were using, just to give you a sense of these groups that we're comparing. In all analyses, I included one set of covariates, including sex, principal components indexing, technical variation, and what blood cell counts. And then when I do these kind of more statistically more powerful tests using dose response, I'm going to include another set additional covariates. Okay, so first question, do previously reported cannabis methylation associations replicate in a group of middle-aged, long-term cannabis users from an independent cohort? And I'm going to show you the comparison of long-term cannabis users versus non-users on that set of 246 methylation sites reported in the previous 8 studies on the topic. This is a volcano plot showing the mean difference between long-term cannabis users and non-users in terms of those 246 methylation sites. This dashed vertical line indicates there's no difference in methylation for long-term cannabis users versus non-users. Positive scores, right, to the right of the vertical line indicate that long-term cannabis users showed greater methylation or hypermethylation. And then the negative scores showed that long-term cannabis users showed less methylation or hypomethylation relative to non-users. And what you can see here is in general, the long-term cannabis users, when they did show hypomethylation, or when they did show altered methylation compared to non-users, it was on average hypomethylation, right? We're seeing all the effects where long-term cannabis users are showing less methylation relative to the non-users in the cohort. And the difference between the red and the blue dots here is that the blue dots are adjusted for testing 246 sites. So we're adjusting for multiple testing. Next, how do long-term cannabis users compare with long-term tobacco users? First, I'm going to show you a comparison between long-term tobacco users and non-users for that context, right? Because we know what the long-term tobacco users should look like based on previous literature. And then after that, I'm going to compare our long-term tobacco users and our long-term cannabis users. So again, this is a volcano plot comparing long-term tobacco users in the cohort to non-users, people who never used tobacco or cannabis in the cohort. And the findings look pretty similar to cannabis, right? We're seeing mostly that the long-term tobacco users showed hypomethylation relative to this kind of squeaky clean non-user group in the cohort. And if we do a side-by-side comparison, right, this left panel here is long-term cannabis users versus non-users, and the right panel is long-term tobacco users versus non-users. The findings look remarkably similar for cannabis and tobacco. I want to point out that the effect sizes are slightly larger for tobacco. Okay, if you look at these effect sizes down here, these are standardized effect sizes, by the way. The effect sizes are slightly larger, but the profiles look similar for cannabis and tobacco. And now I'm going to directly compare long-term cannabis users and long-term tobacco users. And this is the plot. This shows across the 246 methylation sites, very little difference between our long-term tobacco users and our long-term cannabis users. In fact, there were only 3 markers out of 246 that survived adjustment for multiple testing. And those 3 are over here showing long-term cannabis users show greater methylation than the long-term tobacco users. Okay, Next, I'm going to show you, those were the group comparison results, which are fairly straightforward to understand. Now I'm going to show you these tests of dose response associations, where what I did is I took these prospective assessments of past year cannabis use at each study wave from 18 to 45, and I counted the number of study waves at which a study member reported using cannabis regularly, in this case, 4 or more days a week. Okay, so somebody who never used cannabis would be counted as 0 days of use at every single study wave, versus people who used cannabis but they never used regularly. People who used cannabis regularly at least 1 wave, 2 waves, 3 waves, and 4 waves. And so this was our continuous quantitative exposure in the next set of analyses. It's statistically more powerful to test dose response associations. Okay. So really this test is important because I'm going to start testing whether there are alternate explanations. I'm going to control for childhood socioeconomic status, low self-control, and tobacco, alcohol, and illicit drug dependence. And again, there are a lot of results here, so I'm just going to make a couple of key points. One, what's highlighted in red are dose response associations between persistence of regular cannabis use over many years, ages 18 to 45, and each CPG site, right? And again, there's 15 listed here, but we tested all 246. And this estimate shows that for every increase in persistence of regular cannabis use, this particular CPG site became less or more hypomethylated, so less methylated. And this is when I'm not adjusting for any covariates. You can see when I add in here covariates for childhood socioeconomic status, childhood low self-control, and family history of substance dependence, the association really doesn't change. But when I include covariates like persistence of tobacco dependence, we see that the association is reduced. Now it's reduced, but it's still statistically significant. And overall, across the 246 CPG sites, when we did these 246 tests, we found 9 CPG sites. That's what these little markers here are telling you, 9 CPG sites, that survived adjustment for all covariates and adjustment for multiple testing. Okay, so I want to summarize the results of the qualitative group comparisons and the quantitative dose response tests. For the qualitative group comparisons, we found that there were 17 CPG sites that were different for long-term cannabis users versus non-users. And when we did the tests of the dose response, we also found 17 overall when we were using kind of the same set of covariates, just sex, technical variation, and white blood cell counts. And across those 2 sets of analyses, they had 16 CPG sites in common. And then here, when we further adjusted those tests of dose response for all of those covariates, childhood socioeconomic status, family history of substance dependence, persistent tobacco dependence, there were 9 CPG sites that were robust to covariate control and survived adjustment for multiple testing. Next, do any of the cannabis-related methylation markers represent meaningful biological associations? Here, I tested correlations between cannabis-related methylation marker levels and whole genome gene expression. And what I can tell you here is that we found negative associations with a number of genes. So in particular, the more a person showed cannabis-related hypomethylation, there was higher gene expression of several genes. And I'm just going to go quickly through this for the sake of time, but the genes are showed here. This arrow is where the CPG site, the cannabis-related CPG site originated, and it's showing negative correlations with gene expression, in particular, for example, AHRR gene expression. So what I want you to get from this slide is that when we took these 9 methylation markers that survived adjustment for all our covariates and were robust to multiple testing, we found that there were negative correlations with gene expression. So the more hypomethylated, the higher the gene expression. Finally, does quitting reverse differential DNA methylation among long-term cannabis users? And again, I'm just going to select those CPG sites, those 9 CPG sites that survived covariate adjustment and adjustment for multiple testing, and show you here these group comparisons. What this figure is showing you is differences between, or CPG sites at age 45 for those 9, for non-users in the cohort, people who never used cannabis, right? Long-term cannabis users, and then quitters, people who had used cannabis regularly, but by age 45 had quit. And what you're seeing is that relative to the non-users, our long-term cannabis users were showing hypomethylation, right? So they're to the left of this vertical line relative to the non-users, but the cannabis quitters, they're sort of intermediate between the non-users and long-term users, suggesting that their hypomethylation is not as extreme as the long-term users, meaning there might be some recovery from quitting. And by comparison, here are the results of our analysis of quitting for our long-term tobacco users. And we see a very similar pattern where the long-term tobacco users are showing hypomethylation relative to the non-users, but the quitters are kind of intermediate. They almost look like the non-users. Again, this is a well-replicated finding that when a person quits smoking tobacco, altered DNA methylation reverses back. So quitting helps. Okay. Key take-home points. We found of the 246 CPG sites that we tested, CPG sites selected from the literature, 16 were replicated across our tests of group comparisons and our tests of dose response. And then that was reduced to 9 after additionally adjusting for childhood covariates like socioeconomic status, as well as persistent use of other substances, including tobacco, alcohol, and illicit drugs. So these 9 were robust to covariate adjustment. Long-term tobacco users showed hypomethylation of the same sites, which actually has some important implications. And cannabis-related hypomethylation was associated with higher gene expression for a number of genes. Finally, we found that effects are likely reversible because quitters, cannabis quitters, showed smaller effects than long-term users. I want to point out that most of the previously published markers, those 246 markers of cannabis-related altered DNA methylation, did not replicate in our cohort. Okay, so what does that mean? Well, in fact, when you looked at those 246 markers that were from the previous literature, only one of them was reported by more than one study. So our kind of relative lack of replication is consistent with the literature. And we think this might be a function of low retest reliability of DNA methylation sites. Our group did a paper a few years back showing that on average, ICCs representing retest for DNA methylation sites was pretty low, right? 0.2, 0.3. And in the current cohort, when we looked at retest reliability of the particular set of CPG sites that we were focused on, the average ICC was only 0.28, showing that if you test someone now, it's really unlikely or not very likely to get the same result a week later, which is a problem. Interestingly, however, we found that when a CPG site had higher retest reliability, it also had higher effect sizes. And that suggests that focusing on CPG sites with good retest reliability might be a way forward for these kinds of analyses. Implications. I want to point out that despite our relatively low replication rate, 9 cannabis-related methylation sites were robust. That was across tests of group comparisons and tests of dose-response associations after controlling for a variety of covariates. And 6 of those 9 that had available gene expression data were related to gene expression in a biologically meaningful way. Cannabis-related hypomethylation was associated with higher expression of genes implicated in the metabolism of environmental toxins, immune system function and inflammatory response, as well as neurodevelopment, synaptogenesis, and neuroplasticity. And we know that higher expression of some of those genes is associated with some cancers, poor prognosis of lung cancer, as well as cardiovascular disease. And I want to point out that long-term cannabis use is fairly inconsistently associated with cardiovascular diseases like stroke and heart attack, and it's not associated with lung cancer. And so you kind of wonder, well, what's going on here? Maybe it's the case that relative to, for example, tobacco smoking, people use cannabis sort of less intensively. And so when a person uses more intensively, these associations may emerge in the future. That's one hypothesis. All of the CPG sites that we identified for cannabis were also had 100% overlap with tobacco. So that has implications for the specific mechanisms underlying cannabis-related DNA methylation. One possibility is that it's actually really difficult to disentangle cannabis and tobacco because most people who use cannabis also use tobacco. And even though we controlled for tobacco, one possibility is our control just didn't really do the job, and that tobacco explains most of the cannabis associations. However, a more interesting possibility is that cannabis and tobacco may independently affect DNA methylation. And some evidence suggests smoking as a potential mechanism, particularly the fact that cannabis and tobacco were both associated with CG05575921, which is robustly associated with tobacco smoking, and particularly smoking not non-smoked tobacco. A key question is whether THC exposure might also be a mechanism by which cannabis alters methylation. And we've seen animal studies actually show a causal effect of cannabis use or THC administration on DNA methylation. So perhaps it's a little more surprising that we didn't find any CPG sites that were unique to cannabis or not shared with tobacco. And I just want to point out that maybe it's not actually all that surprising because THC and nicotine affect shared brain pathways. They also, the endocannabinoid and nicotinic systems, appear to interact, with one system modulating the other, suggesting, they could share these, again, biological pathways. And strikingly, epidemiological studies have shown that, like cannabis, tobacco is associated with similar health outcomes, including psychosis, cognitive impairment, MRI-assessed brain structure, and periodontal disease, which underscores the possibility that cannabis and tobacco may share biological pathways. Some of that might include smoke inhalation, but some of it might not. Okay, 4 main implications. Long-term cannabis use could affect DNA methylation in similar ways to tobacco, possibly or at least partly through the shared mechanism of smoke inhalation. Research on whether cannabis-related hypomethylation and associated alterations in gene expression result in the development of disease is needed. Okay, because again, we just showed that cannabis users had altered DNA methylation. And the next question is that altered DNA methylation now at age 45 linked with the development of diseases over the next 15, 20 years? Third, at a time when cannabis and cannabinoids are increasingly touted and used for salutary effects, it's important to recognize that the epigenome is going to be responsive to long-term cannabis use, regardless of whether use is medical or not. And I think this is very important for medical users to understand. Finally, cannabis cessation, good news, could reverse altered DNA methylation. That's all I have for you. Thanks for your time.